going on, Mark?
Hey, Steve, not much.
What are we talking about this month for CME?
We're talking about assessment, and let's talk about some stroke stuff.
Stroke assessments, perfect. So we're going to talk about a little bit of pathophysiology of the different types of stroke. We have ischemic and we have hemorrhagic. What else are we talking about?
We're going to review some of the components of the stroke assessment.
All right, we'll talk about the protocol, the suspected stroke protocol, and some of the changes you may have seen.
Yeah, there's been some changes starting January 4th. Huh?
Absolutely, yeah. We'll talk about those.
And we're going to talk about some case studies where we're going to give you some examples, where you can build some images in your brain to think about what these folks look like.
All right, Mark. So we talked about the different types of strokes we had. We have ischemic and we have hemorrhagic. Tell me a little bit about the two.
So your ischemic strokes are either going to be thrombic strokes or embolic strokes.
What's the difference between the two? Why are there two different types of ischemic strokes?
Well, because they're both blockages, which cause an area of your brain to be angry, right?
Lack of oxygen.
Lack of oxygen, just like in your heart. And so a thrombic stroke it's where you have a clot that forms in one of the vessels in your brain, and usually that's from some underlying cause like hyperlipidemia, hypertension, smoking, obesity, something like that. And then embolic strokes, that's usually where you create an embolus or a clot somewhere else in your body. You know, if you think about DVTs.
They travel up from the rest of the body.
So any clot, the definition of the clot, I guess, would be kind of where it lands. If it lands in your lungs, it's a PE. If it lands in your lower leg, it's a DVT, so on and so forth.
So in hemorrhagic strokes, when we talk about hemorrhagic, there's three main hemorrhagic strokes, right? And it really has to do with the location of where they're at.
Exactly. So you got subdural, subarachnoid, and epidural. And we'll go into those a little further, I think.
Perfect.
Moment, right?
Yeah, absolutely. So let's talk about the different differentiations between the two, right? So ischemic strokes, like how common am I going to see them?
That's the big one. That's one you're going to see most often. About 87% of the time in the field, that's what you're going to be dealing with. Those symptoms for those patients, they vary on the location within the brain where the clot has formed, where the ischemia is happening. So you're going to be looking for a focal deficit, most importantly, a big focal deficit.
And when you talk about focal deficit, you're talking about like focused on one specific part of the body. So if I have weakness on my left leg, right, that's a specific area within my brain that's not getting oxygen.
Correct.
Okay,
right.
Perfect.
Yeah, and you kind of almost relate it like a 12 lead. Like when you look at a 12 lead, where you see ST elevation is where the heart is having a problem. So where you see deficit in the body is where the brain is having a problem.
Right. So then the most common type of blockage that you're going to see is going to be in the middle cerebral artery, and it's one of the cerebral hemispheres, right?
Right. So definitely it's going to be on one side of the brain or the other.
Correct, right. So what about the posterior strokes?
Those folks, they're going to ataxia, they're going to have problems walking, they're going to have nystagmus, which is that, the eyes jumping movement. Back and forth. Altered mental status could be a general symptom, but remember, you're looking for those focal deficits, and they may have some vertigo as well.
Right. And then, so you said hemorrhagic is going to be a little less common, right?
Yeah, about 13% of the time.
13% of the time.
Yeah.
How, where in the brain would be something I'd see more common? Like, what type of hemorrhagic stroke?
Well, 75% of the time, it's going to be from the subarachnoid hemorrhages. And that's usually from some sort of like a ruptured aneurysm. Most of the time, about a fifth of the time, 20%, it's usually could be related definitely directly to some sort of event like where they're exerting themselves and their blood pressure, they're raising their blood pressure. Exercise,
defecation, sexual intercourse.
Sex, that's right.
Right. Yeah. Right. So just that pressure increases. It's already a weak vessel, and
they've popped it. Yeah.
Right.
Yep.
All right. What else do we want to talk about here? We got much more. Well, which one's more life-threatening?
Definitely hemorrhagic.
Hemorrhagic for sure.
Strokes have come such a long way in the past 20, 30 years or so.
Oh, yeah, absolutely. We didn't even used to call stroke alerts years ago. Right?
Yeah, they would just sit them in the ER because they didn't have. Now there's the technology's out there. They go up there and grab clots out, and it's great. So it's really important.
So let's talk about the different direct symptoms for each one of those. Let's talk about subdural hemorrhage, right? We talked about general symptoms, right? We talked about altered mental status. Maybe they stop eating or drinking, right? incontinence. Maybe they're acting goofy. They're not
Right.
really acting right.
Yeah.
Right. We talked about that goofy grandma. We'll see that in a
Yeah.
little bit.
Yeah.
Right. It's just something's not right.
That's
You're
correct.
talking to the patient. You're doing your assessment. You're trying to get some information, and they're just not acting right.
We'll paint
Right.
that picture here in a moment.
Right. What about the subarachnoid hemorrhage? How are they going to present?
That's the person that has the classic severe onset headache. They're telling you it's one of those statements that you just really need to cue in on and say, this is the worst headache of my life. They have maybe some episode of loss of consciousness. They may degrade into having a seizure.
Oh, yeah.
But sometimes they may just have like a stiff neck.
Yeah, that nuchal rigidity right here, right?
Yeah.
Absolutely. And then we have lastly we have the epidural hemorrhage, right? And that presents like with an impact, LOC.
Yes, some kind of trauma.
Yeah, transient lucidness, right? They'll be lucid and acting normal, perfectly fine. Then all of a sudden they'll kind of go unconscious on you.
Yeah, take that dive. That's right.
Perfect. So, Mark, when we talk about the different types of symptoms, we talked about that there's like traditional symptoms, and then we have non-traditional symptoms. What are the traditional symptoms that we're going to see?
Usually numbness or weakness to a very specific part of the body. Could be aphasic. You know, they're not talking to us, but just make sure. I think it's important though to emphasize that if somebody isn't responding to you, it's maybe a language barrier too.
Oh, yeah,
you're going to
absolutely.
take that into
Yeah.
consideration.
For sure.
Yeah.
What about like visual deficits?
Oh,
Could that be
absolutely.
is that
Absolutely.
like a common thing that you could see? Maybe dizziness, right? We
Right.
talked about headaches.
Severe headaches, right? The dizziness, again, just remember that dizziness is kind of a general symptom that, if we're dealing with 87% of the time, they're probably going to be presenting with some sort of focal deficit.
Right. When you talked about the weakness, it's usually going to be on like one side
One
of the
side.
body.
That's
right?
correct.
Right. That's that focal that we talked about
That's
earlier.
correct.
What are some different non-traditional type of symptoms that we might look out for?
Well, first I want to say that these are less common. These are definitely less common things. They could have a syncopal episode. They could just have general weakness, altered mental status, maybe difficulty swallowing.
Right, dysphagia.
Yeah, there's been some weird ones. Again, these are kind of zebra examples, but they could have like hiccups. Really.
Who would have thought having chronic hiccups, been going on for hours or days?
And they have actually had a stroke.
That's crazy.
Right.
What about like a seizure? You see seizures as a symptom?
It could be, absolutely.
Like maybe a bleed or something,
Well,
irritation?
certainly, yeah. I think it's when you see these general symptoms, you definitely have to go back and make sure that you have related these symptoms to a very thorough history.
Right. So you talk about a really good history, super important. We talk about doing our physical exam. What about doing, when you're talking about your physical exam, we use a fast ED, right?
Yes, and what we've done for this month, we have an entire separate video, done excellent example of how to perform that fast ED. So we're going to kind of skip over that one for right now, but make sure that you emphasize that quite a bit. When you're performing that physical exam, you want to make sure that you are definitely, you're focused on confirming the stroke diagnosis and that you kind of exclude those mimics, which...
What are some different mimics that we might see?
Could be seizures, Todd's paralysis. I mean, they could have an infection. So if they've got a fever and a symptom, like meningitis or encephalitis,
I wouldn't have thought about that.
Yeah, if they've got a fever, it's probably not a stroke. I mean, it still can be affecting their brain.
What about like hypoglycemia? Can you have like similar symptoms for that?
Oh, absolutely.
Yeah.
So it's certainly, I know it's not part of the fast ED anymore, the G, but absolutely you have to check their sugar and make sure you rule out that possibility.
Right. And then lastly, we have syncopal episodes, right?
Syncopal episodes,
yeah.
We want to make sure when we talk about syncope, you want to make sure that their description of, I passed out for just a moment, but then I woke back up and I'm fine, with the epidural bleed, describing the epidural bleed, isn't being interpreted as syncope.
Okay.
From like a cardiac problem.
Yeah, you're right. Well, let's talk a little bit about the protocol, right? So suspected CVA. Just real briefly, talk to me about the time frame. When would I want to go ahead and call a stroke? Like how many hours?
Well, first, let's emphasize that we need to make sure we know when they were last seen normal.
Oh, yeah.
All right. So
why is that important?
Well, because it's important on how the hospital is going to be able to treat the patient.
Yeah, certain treatments you you can't do over a certain amount of time, right?
Exactly.
Like giving
That's right.
thrombolytics for somebody that's had a
Right.
stroke over
Exactly.
the 3.5 hours or more, right? Causes more harm than good sometimes.
It certainly could.
All right. What about if they woke up in the middle of the night in the morning and they're
So,
experiencing symptoms?
That's a good example. People wake up with a stroke. Well, what happened? They probably had that stroke in the middle of the night sometime. We want to make sure that we capture the last time they were seen normal. When
So
was
if
the
you
last time?
saw them at 9 p.m. when they went to bed and acting completely fine, and in the morning you woke up at 6 o'clock in the morning and they're just not acting right.
Right.
The onset time was the last time I saw them, right?
That's correct.
Right, because we don't know when it happened in the middle of the night.
Right. But
Okay.
still, the key number here is it's within 24 hours.
So we still call it stroke within symptoms of 24
Yes.
hours?
Mhm.
Okay. And then we have the two different types of hospitals that we can take into, right? We talk about primary versus comprehensive.
That's correct.
And in that stroke assessment video, they talked about we get a score. What score would indicate that I would have to take a patient to a comprehensive?
Any score of 4 or greater.
4 or greater? Okay.
That's good. Yeah.
And there's some other criteria that's in there as well, right? So we talk about like 4 or greater. We talk about maybe they have a suspected intracranial hemorrhage, maybe any previous intracranial hemorrhage, right? It had a previous bleeds at some point, maybe a brain tumor, cerebral aneurysm. What about like head trauma? They had recent
If they've had
ground
recent,
level fall.
yeah, if they had recent head trauma, head or spinal surgery, or if they've
okay.
had a stroke in the last 3 months.
Oh yeah, definitely higher risk if they've had a stroke in the last 3 months. They can also have another criteria: active bleeding, internal bleeding, right? A known bleeding disorder that can build up clots and increase your risk for a stroke,
Again, emphasizing, got to take a good history.
right? And what about any history like taking anticoagulant medication?
Oh, absolutely. Yeah.
Do we count aspirin as one of those?
No,
I don't think we
no,
do, right?
No,
It's not really a blood thinner. It's just
No, aspirin works just on platelets. It's not
okay.
a blood thinner.
Right. So we determined that they met the criteria. We take them to a comprehensive stroke center. Is there anything else I need to know about that protocol? Like any other updates?
Yeah, so it's they're emphasizing now that we want to make sure that we try to get a 20-gauge IV catheter in the right AC.
Oh, the right AC. It's
Yeah,
important. Okay.
yeah. And that's something to do with it's better for the people in CT and radiology. So,
Okay, cool. What if I suspect intracranial hemorrhage? What about positioning en route to the
well,
hospital?
yeah, you can lift their head up about 30 degrees or so.
What does that do for the patient?
It helps reduce that intracranial pressure that might be building. I mean, it's kind of a Band-Aid, but it's the best we can do with what we
I
got.
mean, we're limited on what we can do, right?
Right.
Early transport to notification to the hospital is super important.
Absolutely.
Why is it important that I should notify the hospital super early?
So they can get ready, so
Right.
they can prepare.
Yeah, because if they have a CAT scan room that's full, they're doing a procedure, they need to make sure they clear it out so they have room
Right.
for that stroke. Yeah.
Yeah. And lastly, I want to emphasize that we want to try to be off scene. Our goal is 10 minutes or less.
10 minutes or less.
10
Why?
minutes or-
Time is tissue, right?
Time is tissue.
Just like
that's right.
we having a heart attack, and the longer we wait, that tissue's dying.
Time is
So
tissue, time is brain.
so
It's all the same.
Early notification to the hospital, get off scene within 10 minutes.
Yeah.
Perfect. What about those case studies? You want to talk about a little bit?
Absolutely.
Give you some scenarios?
Yeah,
Let's talk about
go over
those.
some of those.